Hello, I'm Dr. Sean Salonga from White River Medical Center, and I will be presenting a case on esophageal squamous cell carcinoma in an immunosuppressed patient with rheumatoid arthritis. Before I begin, I would like to thank my colleagues Dr. Krishna Vidala and Dr. Sai Desikan in our Department of Internal Medicine, and I would also like to thank Dr. Deborah Johnson in the Department of Pathology as well as Dr. Raman Desikan in the Department of Hematology and Oncology. To begin, we should note that the incidence of esophageal squamous cell carcinoma, or ESCC, is decreasing in the Western world. In our case, we have an occurrence of locally advanced ESCC without the normal causative agents such as recent smoking or alcohol intake. This prompted a search for an alternative etiology, which included achalasia and immunosuppressive therapy. We would like to explore the causation and clinical associations of these rare etiologies. So in short, our patient is a 66-year-old male who presented initially with an unproductive cough, but later had what was described as a bloody vomitus and sputum. His relevant past medical history included achalasia cardia, for which a myotomy and Nissen fundoplication had been performed 20 years earlier. His RA was also treated with TNF inhibitors, golimumab, and etanercept. For family history, his mother had unspecified cancer, and his father had diabetes and coronary artery disease. Pertinent social history includes a less than 5-year period of smoking while he denied alcohol or illicit drug use. After making sure he was hemodynamically stable and not actively bleeding, we obtained a CT scan of his chest which showed a soft tissue lesion measuring 4.5 centimeters transversely and 7.4 centimeters craniocaudally in the mediastinum. He underwent upper endoscopy, which revealed a large 8 cm by 2 cm mass in the middle third of the esophagus, and a biopsy revealed squamous cell carcinoma. Further pathology showed that this was not related to HPV activity. This was done through negative P16 expression, which is usually positive in HPV-related carcinoma. Our discussion will focus on achalasia cardia, which is a rare disease with incidence rate of 0.5 to 1.2 per 100,000 individuals, with ESCC being an infrequent complication. There are a few causative factors for ESCC that are posited. This includes retention esophagitis from food stasis leading to chronic inflammation and dysplasia, as well as the increased incidence of gastroesophageal reflux from lower sphincter myotomy. Given his history of TNF inhibitor use for RA, this may also play a role in development or rapid progression of ESCC in our patient. TNF inhibitor therapy has also been associated with oropharyngeal, anogenital, and cutaneous squamous cell cancers mediated by HPV. As latency from diagnosis of achalasia and the local extent of disease are consistent with achalasia-induced ESCC, the role of TNF inhibition in the pathogenesis of ESCC in our patient is probably minimal. Unfortunately, most of the cancers observed in patients with achalasia are advanced, and there are no clearly established guidelines for surveillance after achalasia diagnosis. Therefore, strategies such as molecular screening should be explored. Thank you for taking the time to listen to my poster.